I'm here with Bill Trattler. Bill, you gave a wonderful talk, a really, really, really interesting subject. So you are looking at the prevalence of keratoconus, and it sounds like hasn't this been rehashed? Don't we know? And you've really demonstrated that the answer is no. Let me. Let me provide just a little bit of my own context. We were always told back in the day that keratoconus was something very, very rare, and then in the initial study that was the FDA approval for the first excimer laser, something like 20% of the myopes coming in had some sort of keratoconus flavored corneas, and it's like, whoa, this is not the prevalence that we were told of. We're going to be talking about this wonderful study that you're doing, but before we do that, I want to know how you defined keratoconus, because otherwise it's like asking what is the prevalence of tall people. My definition as a New York person of my ethnicity about what tall is may not be what everyone's idea is. What's keratoconus?
That's a great question. So keratoconus is a abnormality of the corneal shape, and it's usually both a front issue and a back issue. So some people feel the back issue is more important. I personally think there's a lot of findings in the front part of the cornea that are quite critical. So I look at both, and I think there's certain technologies we have available to us that look at both the front and the back surface of the cornea. We can start to identify eyes that have some funny, I hate to use the word funny, but they have some abnormal findings that tell us that this patient either has keratoconus or is about to develop keratoconus or is at risk for developing keratoconus.
So keratoconus, and I'm going to at some point hold your feet to the fire about giving me a definition for keratoconus, but keratoconus is really rare, isn't it?
I do not think it's rare at all. It's actually quite more common than we all think. I think we can see that in our patients that are coming in, like you said, for refractive surgery consultations. It's shocking how many patients actually have findings of early keratoconus or frank keratoconus. And even our cataract surgery patients, we're now doing topography more routinely, and we see keratoconus. Not surprisingly, patients come in, they have no idea they have an abnormal corneal shape, but we identify it during our cataract surgery consultations.
So, when the residents come in and they learn and they say, look, doc, I looked for Munson sign and Rizzuti sign. It's like, forget about that. But at least we can rely on the idea that keratoconus patients with real keratoconus, are coming in with poor vision. Don't they always come in with poor vision?
And that's a surprising thing. I think, thanks for bringing that up. I think, number one, the slit lamp exam is often typically normal in mild to moderate keratoconus. It's a little bit later these corneal findings are visible, and also the vision can be quite surprisingly good. You have patients that can come in with 20/20 uncorrected visual acuity and have very obvious signs of keratoconus. The keratoconus, the C part could be a little bit more inferior, or they just are able to identify those letters and they just have gotten by over the years and don't realize they have a true visual issue.
So tell me what your construction of your study is, and what some of your preliminary results are, and what the outcome measures are that you're using to define keratoconus.
Absolutely. So this is a study that was initiated by the International Keratoconus Academy. Barry Iden, who's in Chicago, is really the key person here, and he really got the study going. And it's basically a study that's based in Chicago and identified children that failed vision exams or identified to have visual issues. It didn't matter what the visual issue was. They were sent in for an eye exam to see what's going on, and Oculus was kind enough to donate a Pentacam so that every child that came in had screening with a Pentacam. And so they were able to screen so far over 2,000 children between the kindergarten and 12th grade for abnormalities on Pentacam.
And these are not children who are coming in with visual problems. This is just the all comers sort of.
No. I would say there actually are patients with children with visual problems. So it's not. This is not really a prevalence of every single child in every single classroom. It's really the kids from all the different schools that were failing, weren't seeing, or having some issue that was identified that said, okay, we really need to send you in for a vision exam. And maybe they just need some glasses. Maybe they're a little nearsighted. Maybe farsighted. They just weren't seeing well. It didn't mean that they couldn't be correctable 20/20, but they didn't have perfect 20/20 uncorrected vision, and so they were sent in for an exam.
And of course, I mean the stakes here are much higher than they were, because there's now a treatment for this. It wasn't just sort of diagnose adios. So how common is keratoconus? keratoconus?
Right. So in this study so far, there's about 2,000, a little over 2,000 children. They had about close to 4,000 readable pentacams. Just sometimes the kids, if you're really young, it's hard to capture. And of those close to of those pentacams, it turned out that almost 20% had some abnormality on the pentacam that was consistent with a finding of possible early keratoconus. So it required us to review it, but there were little flags that said, okay, we need a reader to say, does this child have keratoconus or not?
Huh. So what are you now? Is this study completed? Let me ask you that first.
So there's about a little bit over 700 abnormal topographies that were identified, or pentacams that were identified, and of those, we've reviewed 10%. And of the 74 that we reviewed, actually 73, two different reviewers both agreed that the pentacam was consistent with either early keratoconus or suspect or actual frank keratoconus. So only one eye that had a flag was felt to be normal.
Yeah, I'm going to ask you to speculate on something because it's not the scope of this study. Presumably, you are picking up keratoconus. Your setup is much more sensitive than the way that we picked up keratoconus previously, and that's obviously true because you're finding a prevalence that's much higher. I'm going to ask you to speculate whether you think that all of these children will go on to progress, or are some of these kids just kids with funny-looking corneas?
Right, and that's a great question. And certainly, I don't think every child has abnormal finding needs to necessarily have cross-linking. That the suspects can be followed, but obviously the kids that are identified that have actual keratoconus, they're going to, of course, be sent for cross-linking in the study. But the other children that are borderline, maybe they're going to be that way for the next 5, 10, 15 years. We don't know that, so that's going to be the continued follow-up of these patients is important. When we identify a patient with an elevated eye pressure, we don't always treat them right away, but we know to watch them every single year. So this is identifying children early. We're going to watch those kids that are on the borderline and see what happens. But it's critical that they're watched every year, not just sent off and not seen again.
Now, I'm not asking you whether surveillance with Pentacam over the grand scale of this country is feasible. That's not what I'm asking. What I want to ask is, just with the preliminary results that you have, how important is school screening for keratoconus?
Great. So I think this is telling us that school screening actually children with vision issues that are they may have signs of keratoconus more than you can't just look at the slit lamp and if they have a normal slit lamp say, oh, we don't need screening. They may have best corrected visual acuity of 20/20. Actually, the vast majority of the kids that we found have 20/20 best corrected visual acuity. So the key is that they just need a screening test early to try to pick up these children early so we could follow those that are abnormal on a more longitudinal basis.
Bill, this is really, really wonderful stuff. It's a little frightening. I mean, because the stakes are very high and there's a window for treatment. But it's really, really valuable stuff, and it's the sort of finding that should really change things. I mean, this is ultimately a public health issue. I want to thank you for bringing this to us, and Bill, I particularly want to thank you as always for being so very generous with your time with us today.
Thank you. My pleasure. I love being able to help.